Good evening to all. On behalf of the Honorable President of Dental Council of India, Dr. Dibyendu Majumdar, it gives me immense pleasure to welcome you all to the seventh webinar of this wonderful initiative by the Dental Council of India. This has been a unique program which is benefiting thousands of students, practitioners, and teachers across the country and also around the world. I would like to congratulate the entire team led by our beloved President Sir, our hardworking Secretary Dr. Saha, the Executive Council members, and all the Dental Council members and the back-end staff for putting together this most useful program. All the previous seminars have been very beneficial with a lot of take-home points for the attendees. The last few months, all of you must obviously know that we have been flooded with webinars from around the globe on COVID protocols to be followed in the dental clinics. We have also received very appropriate guidelines from the Dental Council of India and the Ministry of Health, Government of India. As our states begin to relax these protocols and more patients start visiting clinics for rehabilitation, which has also been kept pending for the last few months rather than emergencies, we need to assess our sterilization and disinfection measures related to prosthodontics, especially those regarding impression materials, and models. And very little has been said about this in all the dental COVID webinars that have been going on for many months for now. It is also extremely important to streamline the protocols for sending and receipt of work from our clinics to the dental laboratories so that even this source of cross-contamination is eliminated. Before we proceed on to the lecture, I would like to give some instructions on behalf of the Dental Council to all the attendees. The DCI webinars are free of cost for all attendees thanks to the Dental Council. The attendees will have to register for each webinar separately. At the time of registration, complete and proper details must be furnished since the same will be captured for generating e-certificates or CDE points. No request for any change or modification in their details shall be considered. An e-certificate of attendance will be conferred to all the attendees, including undergraduate students, postgraduate students, international attendees, non-dentists, on their registered email. CDE points will be awarded only to the dentists registered with State Dental Council or Tribunals of India. Certificates will be sent to the attendees by email within 3 days of conclusion of each webinar for those who have attended the entire session of the webinar uninterrupted. Please check your junk email folder also, just in case the certificate email got delivered there instead of your inbox. Just to reiterate again, you should have attended the entire program uninterrupted, including the question answer session, and also make sure that your email ID is given correctly so that you can receive the certificates. I am also extremely happy on behalf of the Dental Council to announce the top 5 dental colleges in the country in terms of attendance for the webinar conducted on 9th August 2020. Sardar Patel Postgraduate Institute of Dental Medical Sciences, Lucknow; Best Dental College Science, Madurai; Yenapoya Dental College, Mangalore; Srinivas Institute of Dental Sciences, Mangalore; Bojia Dental College and Hospital, Baddi, Himachal Pradesh. We congratulate all of them and we request same kind of support and enthusiasm from all the dental colleges in the country. It now gives me great pleasure to introduce our speaker of the day, Dr. Veena Jain. Dr. Veena Jain completed her undergraduation in 1993 and post-graduation in 1996 from the prestigious KGMC, Lucknow. After that, she joined the prestigious All India Institute of Medical Sciences, New Delhi as a senior resident and is currently working at the same institution as professor and head of Department of Prosthodontics. She is a life member of the Indian Dental Association, the Indian Prosthodontic Society, the Indian Association of Cleft Lip, Palate and Craniofacial Anomalies, and she is also a fellow of the International College of Dentists. She has worked on different research projects funded by ICMR, DBT, DST, and her main area of research is geriatric prosthodontics. She has more than 50 publications in different national and international index journals. She has conducted many CME programs on different topics like full mouth rehabilitation, cast partial dentures, implant supported overdentures, implant supported facial prosthesis in national as well as international conferences. Dr. Veena Jain, the floor is yours.
Yeah. Good evening to everyone who is present here this evening. So before starting the presentation, I want to thank the President this year and the Secretary Sir and the entire team of the DCI who is associated with this activity for giving me this opportunity to present in front of you. Today I will speak on the management of impressions on the models during COVID-19 period. I selected this topic because the impression are integral part of the prosthodontics and simultaneously they are the most common source of the transmission of the infection among the dental personnel and to the laboratory. So to understand how we can prevent the transmission of the infection among the dental personnel, we have to know how an infection take place. So for any infection to take place, a pathogen is required which has sufficient virulence and present in sufficient number. And a source is required where this virus or the pathogen can survive and multiply. Then they need a mode through which they can transfer to the susceptible host. And in the host, they need a portal through which they can enter to the host. So different type or the many pathogens are prevalent in our community. For many of them, immunization is available. But in today's scenario, we talk about the COVID-19 for which research are going on yet. As we know that this COVID-19 or the corona is caused by the coronavirus. This is an RNA virus and which has a lipid membrane with protein spoke on the outer surface. This protein spoke attached to the receptors on the cell membrane of the human being and through which they enter the cell of the human. So any of the pathogen or the pathogenic microorganism can enter the human body through the different routes. That is percutaneous, that is through the sharp needle or the instrument while working onto the patient can pierce our skin or the mucosa. So chances of in such cases infections are very high, or they may be entered through the infected oral lesions into the non-intact skin. Again, the chances of receiving the infection are very high in such cases. Or they may transfer to the dental personnel through the aerosols, inhalation of the aerosols. In these cases, the chances of infections are moderate. And when we are touching the infected surfaces in the operating or in the dental office, the infection can be transferred, but the chances are very less in such cases. So to prevent the occurrence of the infection, we have to do a strict protocol for the decontamination procedure. In the decontamination, we can divide it into sanitization, disinfection, and the sterilization. Sanitization means it's the physical cleaning just to reduce the number of the microorganisms or to reduce the bioburden. So the disinfectant will be more effective. And disinfection is a process in which all the vegetative form of microorganisms is killed. But some endospores remains, bacterial endospores remains there. But in sterilization, it kills all form of vegetative microorganisms along with bacterial endospores. So now we have to think about which item has to be sanitized or disinfect or sterilized. That depend on where they come or where they are used. The instruments which come into direct contact with the tissue or vascular spaces, those are termed as critical and they have to be sterilized. And those come in contact with the mucous membrane and non-intact skin, those instrument sterilization or high-level disinfection can work. But the instrument which come in contact with intact skin only, not even the mucous membrane, for that intermediate or low-level disinfectant can work. So for the sterilization and disinfectant, different methods are available. Like the physical method, we can use either dry heat, wet heat, irradiation, plasma sterilization, or different chemicals are available for the sterilization as well as the disinfection. So these disinfectant, on the basis of what they can microorganisms they can kill, they have divided into high level disinfectant which can kill most of the vegetative microorganisms, but they can kill only some of the bacterial endospores only. And intermediate level of disinfectant destroy all vegetative bacteria, including the Mycobacterium tuberculosis, which is considered to be difficult to destroy, Mycobacterium tuberculosis, and they can destroy even kill the lipid envelope viruses as well as some non-lipid envelope viruses and fungal spores, but even not the bacterial endospores. And low-level disinfectant destroy all the vegetative microorganisms except the Mycobacterium tuberculosis and only some non-envelope viruses and not the bacterial endospores. In our hospital, we are for the surface and the equipment disinfections, we are using the Vacilor. It is composed of mainly ethanol and the 2-propanol and 1-propanol, and it is a wide spectrum disinfectant. They have said it can disinfect the surface within 25 seconds. And for head disinfection, we are using the Sterilium. It is again alcohol-based, and it is wide spectrum. And they said it can disinfect the hand. For the routine, if we are disinfecting the hand within 30 seconds. But if we are disinfecting the hand before the surgical procedure, it's better to rub it for 1.5 minutes. And to maintain the disinfection or the prevention of the transmission of the infection in the dental office or from the dental laboratory to the lab technician, OSHA giving the regulations. I have taken the few important points from the OSHA regulations. Most important is the immunization for any of the infectious disease, not only the dentist, all the associated health workers. And implementing the engineering control. Engineering control here, they want to say the clinic should be very well ventilated, or it should be designed in such a way that it lead to smooth ventilation, or the bacteria will not stay or the pathogen will not stay in the clinic. And we should provide facility for the hand wash before entering into the clinical area. We must prescribe safe handling of the needle, and the disposal of this sharp instrument must be near to the place or to the dental chair. And all the contaminated reusable instruments should not be handled with the bare hands, or we must use the utility gloves before disinfect them. And then further recommended, we should prohibit eating, drinking, or the cosmetic application in the operatory area, and shipping of the contaminated things for discarding into the strong label puncture-proof bags. And they recommended the use of PPE for the employees, all the employees. And if PPE laundering is required for PPE, that must be provided free of cost by the employees. So in prosthodontics, we talk about the transmission of the infection, of the infection control, that is required not only in the clinic, in the laboratory also, and the transmission in between the clinic and the laboratory. So cross-contamination can take place from dentist to the clinical assistant, from the assistant to the technician, and to the patient, and even patient to the dentist. So this is a vicious cycle which carry on. So beside the disinfection and the sterilization, we can use the barrier systems also. Barrier is the most effective way or the practical method for preventing the cross-contamination. Barrier include first and most important is the hand washing with plain or antimicrobial soap, use of PPE where there is a potential for occupational exposure to the blood-borne pathogens. So in this case, what PPE is required? Gloves, mask, protective eye wear, and the face shield, and the protective clothing. So in short, I want to explain how to be precaution, what precaution we have to follow, or what sequence we have to follow when we are washing the hands. First of all, we have to remove all the jewelry and keep it safely. Then rinse the hand along with the lower arm under the running tap water. Then we take out the antimicrobial or the plain soap onto the palm of the hand. Then first we have to rub it onto the palm of the hand. Then each step has to be repeated minimum 5 times. First on the palm of the hand, then back of the hand. Then we have to rub between the web of the fingers. This is very important to rub between the web of the finger. Then tip of the finger, especially the nail area or the knuckles of the finger. Then the thumb must be rubbed separately. Once this procedure is completed, then we have to wash hand along with the lower arm and the cold water and pat dry with the help of the clean towels. If there is any cut or abrasion onto the finger or the hand, that must be covered with the waterproof tape. Then before starting the procedure, we must disinfect our hand. For that, we have to take the disinfectant onto the palm of the hand, and same procedure which we used by rubbing the soap onto the hand, that has to be repeated once again for disinfecting of the hands. And we glove our heads. These gloves should be changed and disposed appropriately after the completion of the procedure. And we must wash our hand not only before wearing the gloves, even after removing the gloves also. And for the sanitizing worker who are cleaning or disinfecting the instrument as well as the slabs and all, they must wear the utility gloves. We notice they have the allergy to the latex or to the powder into the gloves. For them, powder-free latex gloves are available in the market, or they may use nitrile or polyurethane gloves. These are available with and without powders. So whatever suitable can be used. There is a definitive procedure or the technique how to wear the gloves. So first the assistant open the gloves and drop them onto the table, on the sterile table. Then the dentist can pick up the gloves with the right hand. Just he has to fold through the folded portion of the gloves only. Then wear the gloves without touching the outer surface of the glove. We have to wear the gloves. Once we had wear it in one hand, then slide the figure of that hand under the folded portion of the gloves and then wear it. And at this time, we should not touch the inner surface of the glove. Then we wear it and make it, fold it or cover the cuff of the surgical gown. Then after that, we can unfold the gloves we had previously wear and cover it onto the surgical gown. Like we have to follow a definitive sequence of the procedure for wearing the glove. Similarly, the removal of the gloves is more important, because if we are not follow definitive procedure while we are removing the gloves, we may contaminate or infect to ourselves by removing the gloves. So how to remove the gloves? While removing the gloves, we must hold it into the palm area. It's easy to hold from here. Then remove halfway in both the hands, not completely. Then from one hand, we have to remove it completely and hold it into the hand in which the gloves is still there. Then what we have to do, just slide the thumb on the inner surface of the glove without touching the outer surface. Now fold the gloves onto the gloves we are holding into the hand. And now discard it into the bucket which is meant for the to discard the plastic items. Another important question is, does double gloving double the protections? Although it's not double the protection, but the different studies show it's definitely beneficial, as the Tokars and Doll and the Grasso and the Granger, they had supported the person who are wearing the or using the double glove during the surgical procedure or when working, where chances for the infections are more. The chances of getting the infection are 72 or 70% less as compared to the person who are using the single gloves. Even the CDC or the WHO recommended the wearing of the double gloves when we are working onto any infected person. And for the laboratory person who has to handle or working on the instrument where the chances for the splash or the spray or the spatter formation, they have to wear the proper PPE that include the cap, protective IVR, face mask, N95 mask be preferred, surgical gown, and the gloves as well as the shoe covers they have to wear. And these has to be changed daily, after once a day daily, and they have not to go with this PPE outside the clinical area. And another important question is how to take out these PPE from the storage section. For that, we must have a transfer forceps that can be stored either in a sterile jar or may be kept in a liquid, in a disinfectant liquid. So if we compare the surface barrier versus disinfectant, then surface barrier technique required 8 to 10 minutes, 3 to 5 minutes less, or we can say disinfectant require 8 to 15 minutes, take longer time than the barriers which we use to prevent the transmission of the infections. But with the barrier technique, we cannot use it everywhere. It can be used only on certain things, like we can use the light handles, electrical and the mechanical control, head and the armrest of the dental chairs, all the tubing or the cufflinks of the headpiece and the micromotor, those can be covered with the disposable plastics. Like here in the picture is shown, here we have used the cling film to cover the head of the chair, or we can simply wrap the OT towel around the head of the chair, as well as we can cover the complete seat of the chair with the disposable towel. Most neglected part in the dental clinics is the tubing, water tubing or the water lines, from which are the source for microbial biofilm formed in small bore tubing of the dental units. So these biofilms serve as a reservoir where the microbial or the microbes get accumulated. So these tubings has to be disinfected daily, at least once per day in this COVID time. So for that, we can use 1% sodium hypochlorite or the 10% Phospholax can be used for the disinfection of the tubings. And the CDC given the guideline what type of the PPE to be wear by the different dental personnel. They had advised where there is a anticipated use of aerosols or the sputter generated devices, like we are using the handpiece or the air water syringe or ultrasonic scaler. Dental personnel or the clinical assistant must wear the level 3 PPE, or along with that they have to wear the eyewear, mask, gloves and gowns. Similarly, the person sanitization worker who is cleaning the clinic once the procedure is completed also has to wear the same level 3 PPE, except the nitrile utility gloves. They have to wear the nitrile utility gloves, while the surgeon and the assistant has to wear the disposable gloves. But in our institute at the AIIMS, what we are following in the AIIMS, we are following to the procedure room or the clinical area where there are chances for the aerosol generating procedure. We are using the level 2 PPE along with the face shield and the double gloves. What is the main difference in the level 2 PPE and level 3 PPE is the permeability of the PPE or the protective gown we are wearing. Otherwise, it's same. Beside that, level 2 PPE, they have to wear the face shield, they have to wear the double gloves and the long shoe covers. And in the clinical area where we are working on non-aerosol generating procedure and in labs, we recommended to wear the N95 mask, eyewear to protect the eyes, cap, face shield, and the disposable gown and shoe cover. And for the disinfection or the sterilization protocol is the routine protocol as for any of other infectious diseases. CDC further divided the dental team into the different category according to the level of infection or the chances of infection for them to receive. The personnel who are sitting in the office area or the administrative area, chances of getting the infection in this COVID time are very less, while the persons who are providing urgent or the emergency dental care but not involving the aerosol generating procedure, chances of getting the infections are medium, while the personnel who are working on the COVID suspected patient in a room or providing urgent emergency dental care, the chances of getting the infections are high. But the person who are providing the care to a person, COVID-19 patient, and involving the aerosol generating procedure, the chances of getting the infections are very high. So even in our institute, if we are working, they said if we are working in an area which we already know this is a COVID positive patient, then even dental person, we have to wear the PPE3 only, not 2. On the suspected patient, we have to wear PPE2. And we are treating to every patient who is coming to the dental clinic as a suspected COVID patient. Another important concept which is given by the CDC is the unit dose concept. What they said when we are dispensing the impression, dispensing the material, like impression material. So before starting working onto the patient, we must dispense only the required amount so that the contamination of the remaining material can be prevented. And the remaining material which remains after the completion of the procedure must be discarded. So now I come to impression disinfection. So if we have taken the impression, how do we have to disinfect the infection and why to disinfect the impression? As I said, dental impression are the most common source of transmission of microorganism or any other infections. These infections may be categorized into the COVID-19 in today's day or the AIDS, hepatitis, HAP, 1 and 2, and the tuberculosis. So to prevent this iatrogenic nosocomial infection among the patient and the patient occupational exposure to care providers, potential exposure to the care provider, we have to follow the disinfection procedure for the impression. And for the disinfection, first and most important step is the clean or the rinsing on the impression in the dental operator. So for the cleaning of the impression, we have to wash the impression under the running water. Impression surface can be rubbed with the camel hair brush, or we can use the antimicrobial detergents to clean the surface, or we can sprinkle the dental stone onto the impression surface. This will absorb the saliva and help in cleaning the impression surface. By washing, we are reducing the bioburden present onto the impression surface, so the efficacy of the antimicrobial agent increases. Another question which is the how to disinfect the impression, whether to spray or immersion. What technique to be used, that is depend on the effect of the disinfection procedure onto the dimensional stability and the surface detail of the impression. And the other important thing is the effect of the impression material onto the disinfectant. It may reduce the efficacy of the disinfectant. So we have to select the disinfectant according to that only and the technique also. And if we compare whether immersion or spraying, if we compare the two procedures, then immersion is definitely give better disinfection because here all the surfaces of the impression are exposed to the disinfectant. So how to use a spray technique for the disinfection? First, and as I explained, we have to clean the impression as I explained. Then what to do? Just clean impression, just put it into the disposable, either plastic bag, or we can use the box also with the lid. We can use the box with the lid. Then you have to spray the disinfectant in a sufficient quantity. Why to place the impression into the disposable bag or the box with lid? Because we don't want the disinfectant to be spray or spread into the operatory. So it will reduce the exposure to the vapors of the liquid to the dental vessels. But we have to keep the impression into the bag for the recommended time. If we are using the sodium hypochlorite, recommended 1% sodium hypochlorite, recommended time is 10 minutes. Remove it, wash it, then we can pour it or send to the laboratory. How to send it to the laboratory, that I will explain later. In hospitals like us, we can use the box also to transfer the impression or to disinfect the impression when we are using the spraying or the immersion technique. So main advantage of the spray disinfection is it required less amount of the disinfectant, and the same disinfectant which we are using to clean the slab or the environmental surfaces can be used for the spray disinfectant. But main disadvantage is probably not as effective as immersion and can release into the air. In prosthodontics, although we are using different type of the impression materials, So for the different impression material, we have to follow the different protocol for the disinfection. Like when we are using the impression, taking the impression using the impression compound or the zinc oxide eugenol, which we generally use for the final impression. For both the materials, we can use 1:10 dilution or 1% sodium hypochlorite and the iodophor for a specific time period and 2% butadiene. Most of this disinfectant has to be either immersed. This impression can be disinfected either by spray technique or the immersion technique. We have to keep the impression in contact with the disinfectant for minimum 10 minutes. After that, we have to remove it and wash it. For the hydrocolloid, we mainly use alginate and the agar. Alginate is more commonly used than the agar into the clinical practice nowadays. For the alginate, as we know, they imbibe the water. So immersion technique is not preferred with the hydrocolloid. We have to use the spray technique with the hydrocolloids. Most of the time, sodium hypochlorite 1:10 dilution and the iodophor or the synthetic phenols are used for 10 minutes. Or we can use the glutaldehyde also if we are using 2% glutaldehyde. What we can do for any of the disinfectant, if we think spray is not sufficient, we can wrap the impression into the disinfectant soap towels for the recommended time and then unwrap the towel, wash it and pour the model or transfer it to the lab. And if we talk about the elastomers, we are mainly using the polysulfide additional or the condensation silicone in the polyether. Although all of them are the hydrophilic, so immersion technique is not preferred. But especially polyether, which is more hydrophilic as compared to others. So polyether is recommended to be disinfected by the spray technique. For the elastomers also, we can use 0.5% sodium hypochlorite, either spray or immersion technique. We can use 2% glutaldehyde for the immersion technique, or the, as I said, for the polyether is better to use the spray. Nowadays, autoclavable impression material is also available, especially the one from the Poltin. But main drawback when we think about the autoclavable impression materials, we think if they are dimensionally stable, autoclaving will not affect the dimensional stability. The different studies shows that the autoclaving lead to some dimensional changes, and these changes are more prevalent in the first 24 hours, and later on these changes are reduced. And they also said the changes which are evident in the first 24 hours, they are not very significant if we compare with the other techniques. So sterilization is generally used for the all metal instruments or the heat stable instruments. For the sterilization, we can use the autoclaving. And when we are doing the sterilization of our impression trays, we must pre-clean them to reduce the bioburden. Or what we can do, just to, although we remove mechanically all the impression or the plaster which is adhered to the impression tray, we can further use the ultrasonic cleaner. But that must be covered when we are using the ultrasonic cleaner to clean the trays. After recommended time, 2 to 5 minutes, we remove it from the ultrasonic cleaner, then we can wrap them, pack them and autoclave them. Single-use tray has to be discarded after each use. Sometimes we have to disinfect the acrylic, custom acrylic tray. Many times we think we have to take the repeat the impression in the same patient in the next. So in that case, we can disinfect the tray by immersing them in 1% sodium hypochlorite or 2% butadiene. Other prosthetic items which we carry into the clinic or we use them in the clinic is the rubber bowl, like the rubber bowl, plaster spatula, plaster knife, face bow, alcohol torch, and the articulator. These can be disinfected either by immersion or we can simply clean their surface by rubbing with the disinfectant. Then we took the bites in the patient, wax bites. This picture shows the bite we have taken for the partially edentulous patient. Such bites we generally use silicone-based bite registration materials. So their disinfection procedure is same as we use for the disinfection of the silicone impressions. But in case of edentulous patient, we take the wax bite or wax bites. So when we are using the wax bite, although they have to disinfect it before starting into the patient. Same procedure is followed. Once we completed the procedure, we can disinfect them into the, we can disinfect using the spray disinfectant as shown here in the picture, or we can immerse them in either 1% sodium hypochlorite or 2% butyldehyde for 10 minutes. Then we remove them into the disinfectant, wash them, and keep into the mortar. Here, I want to highlight in this time where the COVID infection is prevalent, it's better to avoid placing these bite rims in between the procedure onto the models, because to disinfect the models ideally is very difficult. In any case, if we have placed the bite rim onto the models, then it's better to disinfect the models by spray disinfectant or immersion, minimum 30 minutes for the models. That I will explain. And sometimes what happens, patients comes with orally soiled prosthesis or the dirty prosthesis, either for the cleaning of the prosthesis itself, or maybe for the relining or the repair of the prosthesis, and we find the prosthesis is really orally soiled. So before carrying out any of the procedure, we must clean the prosthesis first. Before that, we have to scrub the prosthesis with the brush and the antimicrobial soap. Then this brush also can be disinfected, and we can keep the prosthesis into the ultrasonic cleaner. Here again, I want to highlight the lid must be closed when we are cleaning the prosthesis into the ultrasonic cleaner. Once the cycle is completed, remove it from the ultrasonic cleaner, run under the tap water, dry, and then we can do the desired work or send to the laboratory for required. So whatever prosthesis is coming to the clinic from the laboratory, those also either they come in a labeled bag that they are disinfected using disinfectant for this much time. If it's not clear whether they are disinfected or not, they must be disinfected into the clinic. But for the disinfection, especially when we are making the cast partial denture, we must follow the recommended time period, because this disinfectant also may have an effect onto the cobalt chromium or the nickel chromium we use in the cast partial denture alone. Recommended is we can use either sodium hypochlorite for 1% sodium hypochlorite for 10 minutes or 2% butyldehyde. And then once we disinfect them, wash them, and then we can store them either in clean water or we can use into the diluted mouthwash until the insertion. Before insertion, they must not be stored in the disinfectant. So now this is about what precaution, how to we disinfect the different things which we are using in the clinical area. The impression, bite rims or the instruments, everything. Now when we are sending to the laboratory, what precaution we have to take, and how do we equip to our laboratory for the disinfection protocols. So all the disinfection procedures must be accomplished prior to delivery any of the dental impression or the instrument to the clinical area. That can be accomplished within the dental operator. Or lab may display a sign that only biological item, clean item are permitted. Why this is necessary? Because to disinfect the laboratory is more difficult than disinfect the things into the clinical area. Potential pathogen can be transmitted to the lab by the orally soiled impression, dental prosthesis or the appliances. And from these impressions, microbes can be transferred to the dental cast. So dental personnel or the laboratory personnel are exposed to the microorganism while they may come in contact with impressions if they are keeping the infected impressions, working on the handpiece, pumice pan, pouring the impression, or they working on the lathe where the chances of spatter or the aerosolization, or they are not well versed with the hand washing protocols. So in the dental laboratory also we must use proper method or the materials for handling and decontaminating the soil incoming item. All the contaminated incoming item should be cleaned first before the disinfectant or before handling by the lab personnel. And lab personnel also must understand proper steps to ensure the proper disinfection of all the materials handled into the laboratory. So for that, a proper communication system between the lab and dental office is essential. This helps in two ways. One is it prevents the duplication of the disinfection protocols and to prevent the potential lab contamination. And if laboratory person is not ensured about the disinfection, then things has to be disinfected in the prescribed method. So there must be a proper communication system between the dental clinic or the provider and the dental lab, as is shown in the picture. The whatever is coming into the laboratory impression must be, or anything must be labeled. What disinfectant is used, what procedure was followed, and for how much time. And this can be written into the work authorization form as well. And similarly, the things are coming from the lab to the clinic mention all these things. This is again, I'm emphasizing the incoming item which are coming into the lab. Either this must be indicated into the work authorization form or they are labeled. If not, then proper protocol for the disinfection must be followed. Similar procedure is for the outgoing outcome from the labs to the clinical area. Now, in short, about the disinfection of the cast, how we can disinfect our model in the cast. As I said, it's very difficult to disinfect the cast because all the disinfectant have certain effect onto the surface detail of the cast or may alter the surface properties of the cast. So always the disinfection of the impression is preferred over the disinfection of the cast. Additional of the disinfection, or what can be done, disinfectant can be added into the water which is used to mixing the cast. We can use for the disinfection either hydroform, phenolic compound, or the sodium hypochlorite, butyl 2%, or the chloramine type. This can be mixed into the water which we use to pour the impressions. Anyway, if there is a need to disinfect the cast, then we must place the cast in such a way the disinfectant must not accumulate onto the surface of the cast, facilitate the drainage. And then we spray the cast with hydroform or chlorine compound and then rinse the cast. Or we can soak the cast for 30 minutes in 0.5% hypochlorite or slurry. Over the hypochlorite, slurry water is preferred because slurry water is formed by, or we can say, saturated solution of gypsum in which the cast can be placed. Another most contaminated thing in the dental laboratory is the dental lathe, where most of the dentures are polished, or sometimes they are used for the gloss, creaming, and the polishing of the dental appliances. So whenever the dental personnel or the labor work on the dental lathe, their protective shield must be down, and they must on the vacuum. So all the spitter must be sucked by the machine itself. And for the pumice also, pumice must be cleaned daily. And for the mixing of the pumice, we can use disinfectant. We can use either 1% sodium hypochlorite, or we can use tincture of green, or soap can be added into the pumice. And we must use only the, like I had explained, the unit dose for the materials in the clinical area. Similarly, here we can dispense the pumice only which is required for a particular case. And remaining pumice must be discarded. Lathe must be cleaned very well, and these buff and all must at least be disinfected at least once a day. Another most important thing is the plaster trap, the most dirtiest part. So these can be disinfected using 1% sodium hypochlorite can be used to disinfect the plaster trap, and these has to be disinfected daily. And all the environmental surfaces into the laboratory as well as into the clinical area should be disinfected and should be same in the clinical area as well as in the laboratory. In the laboratory also, surfaces, as soon as we see they are dirty, they must be clean. But for the disinfection, we must use only the environmental protective agent or which are registered with the EPA. For the cleaning of the slabs, and the sanitary worker must wear the utility gloves. And whenever possible, better to use the barrier surface technology so these barriers can be discarded after each case. Similar to the clinic, in laboratory also we must prohibit or we may display the eating, drinking, smoking, or the applying cosmetics or the handling of the contact lens is not permitted. This is about the how to we have to disinfect or what precaution has to be followed into the laboratory to maintain the disinfection. Now we switch over to the operating room area, how to disinfect the environment or the area where the patients are sitting, waiting area, corridor, or the area where which are used for the donning and the doffing area. Those has to be fumigated daily or maybe in between the procedure if the working hours are too long. As in our institution, we fumigate twice, once in the afternoon at the lunch area and after the completion at the end of the day. For the fumigation, previously formalin was used as this is a carcinogen. So nowadays, a combination of stabilized hydrogen peroxide 11% weight for formalin and the silver combination of silver nitrate for 0.1% is used. Although literature shows we can use the ultraviolet germicidal irradiation can be used for the disinfection of the operatory as well as the office area. But there are many controversial articles are present which not support the use of the ultraviolet irradiation for the disinfection, and it is not supported by the scientific literature. And lastly, most important thing is how we have to discard the waste which is generated in the clinic and the lab. So we can say what is the waste that include the disposable tray, impression material, contaminated packing material, if these cannot be disinfected. So for the disinfection of the things which are or the waste material, everyone must follow the procedure or the rules according to the applicable to the federal, state or the local regulation authorities, what they recommended. And we can dispose the waste in general waste unless the waste which is generated is defined as a regulated waste. So only small amount of regulated waste are generated in the dental laboratories. And the sharp needle or the blades must be discarded in puncture-proof system containers. For the disposal of the waste, they are recommended, different color coding is recommended for the different type of the waste materials. For the sharp needles or the blades, they said we can use the white or the blue box and it must be puncture proof. Yes, here we can see this is a plastic container and these must be kept near to the work area only, so the things can be discarded simultaneously. And they recommended the red dustbin is for the infectious waste. The red dustbin is recommended for the plastic waste which is generated in the clinical area or into the OTs, like the gloves, tubings, those has to be discarded into the red dustbin. While the yellow dustbin is for the infectious waste, like the cotton which is soaked in the blood or the saliva or the human organs or like such things. And the black dustbin is for the non-infectious waste, like the paper, such things can be discarded into the black dustbin. So we have to follow the proper rules which are recommended by the federal government or the state. So I want to conclude my webinar. All the infection control activities are designed to accomplish one goal. That is how we can break the link in the chain of the infection. Or we can say we want to interrupt potential for the transmission of the infection from one person to the another person. It is not very difficult to control the transmission of the infection between the clinics and the laboratory if they work in the close communication or in coordination to each other. And it is the moral and the legal responsibility of the dental personnel to protect himself as well as their patients from the infectious disease. Now the session is open for the questions.
Thank you so much, Dr. Veena, for this extremely informative and very useful lecture. You have provided a great insight into the sterilization and disinfection protocols to be followed for the management of various prosthodontic impressions, impression materials, models, and also how the casts and models and various other things need to be sent from the clinic to the lab, and also how to receive them. This is really the need of the hour during these times. Really, thank you very much. And then we will go ahead and take some questions now. What is the effect? The first question is, what is the effect of COVID-19 on teeth?
Sir, if we say the effect of COVID-19 on the teeth, as such COVID-19, the literature doesn't say anything. The COVID-19 is directly affecting the teeth. But definitely, at the time of the COVID-19, the main concern is about the control of the transmission of the infection, or we have to prevent the transmission of the infection.
Right. So the next question is, you have been talking about immersing the impressions in, and you have also said that that is the best method. Does immersion affect the diamond stability of the impressions?
Yes, sir. Yes, sir. Immersion may affect the dimension stability of the impression. As said, hydrocolloid impression material must not be disinfected by the immersion technique. Similarly, when we use the silicone impression material, like the polyvinyl addition silicone or the polyether or condensation silicone, as these are also hydrophilic. So it's better to disinfect with the spray disinfection protocol, or if required, we can wrap the impression into the disinfection soap towel. So again, disinfectant will come in contact with the all area of the impression.
Okay, thank you so much. What is your opinion about these anti-retraction adopters? You know, I think they are talking about these in the retraction handpieces and other things. What is your opinion about that?
Yes, sir. These are really very useful anti-retraction wall, especially when we are working on the patient. And as in our institution, they say we must treat every patient as a COVID suspected patient, because many patients are asymptomatic. So anti-retraction wall prevent the sucking of the saliva from the patient mouth into the handpiece. So further chances of contamination is reduced. Although in this era of the COVID-19, same aerator handpiece should not be used from one patient to the another without autoclave.
So what instructions would you give for denture patients in this pandemic situation?
Yes, sir. To the patients for the treatment of the edentulous patient, as we follow in our institute, as soon as patient enter into the clinic, we follow a definitive protocol. First of all, we make a hand wash area. We ask the patient to wash the hand. Then we display a video for the patient, so you can see the video how to maintain the disinfection protocol, how to maintain the distancing. And another thing from the patient is we take the history from the patient. They are coming from which area, if they have any symptoms related to the COVID-19, like the infection, they have the fever, cold or cough, and body ache, like these symptoms we can ask from the patient. Then as soon as patient enter into the clinical area, we ask the patient, we give to the patient the shoe covers, because shoes are either shoe has to be removed outside the clinic, or we can give to the patient shoe cover to wear the shoe covers. The patient sit onto the dental chair. So before starting examining the patient, we talk the patient for a while, then ask the patient to rinse with the mouthwash. So mouthwash further, we can use either iodine based or we can use chlorhexidine based mouthwash. Further reduce the bioburden into the oral cavity. So we can use this mouthwash in between the procedure also. And when we are performing the procedure, so when working on the procedure, suppose I'm adjusting the denture. In between that, I want to use the micromotor. We must not forget to clean our gloves itself with the disinfectant solution before touching the micromotor handles. In this way, we can keep control of the transmission of the infection.
Thank you.
And after the completion of the procedure, before sending the laboratory, we make it mandatory to disinfect all the things into the clinical area.
So how do you go about disinfecting dental chairs in probably,
Then
let's say in an AIIMS?
Yes, sir. For the dental chair, we are using the barrier technique also to cover the headrest and the slip-on light handle and those. And we, after completion of the each procedure, we clean the dental chair and the slab, everything with the 1% sodium hypochlorite. So in between the patient, when we suppose we have called the 3 or 4 patients, so we keep call the patient in such a way there is a gap of minimum 20 to 30 minutes in between 2 patients. So then the sanitation worker get ample time to clean the or disinfect the operator.
Next question is about the masks. I mean, everybody talks about N95. Some are safe, some are not safe. The respirator, non-respirator. So, what is your opinion? I mean, what should be used?
We were also initially very confused, but now our institute has given a definitive guideline. They say whenever we are working on the patient, it's better to use the N95 mask without respirator. Otherwise, when we are sitting in the office or going here and there, we can use with respirator. And one more thing they are recommended, because N95, when we are working on the patient, it's not feasible to discard the N95 after each patient. So to avoid the transmission of the infection from one patient to the another, although we are protecting to the ourselves, it's better to we use one medical mask over the N95 mask. So we change that medical mask after each patient. So in this way, we are protecting to ourselves as well as to the patients also.
Right. And some were also asking whether N95 can be, reused and things like that.
Yeah, N95, when we are working on the patient, what the literature said, I searched on the net also, they said disinfection procedure, although they have said they can be disinfected, but that may affect the permeability of these N95.
And does patient also wear a PPE when you're working on in orthodontics?
Patient not wear the PPE because it's anyway patient come with the mouth facial mask only, and if that patient has to remove.
Right.
Many patients ask us, even my patient sometimes, I don't have PPE, how to come to dental clinic? We say you are not required PPE. We will cover the dental chair with the OT towel and clean it.
Also, there are many questions on whether we can reuse a PPE.
So this is very controversial. I can say in our institution, we are not reusing the PPE right now, but I read onto the net now the autoclavable PPE also coming, but I'm not very sure about it.
And how do you avoid fogging of the glasses if it happens during a procedure? Is there any protocol you follow? Is there anything?
Yes, sir. We are using the N95 mask and it's tightly adapted onto the face. Then fogging is not there. If any of the slit is there between the mask and the nose, then specs fogs with the mask.
Some are asking about PPE kits. With using PPE kits, they get rashes on the body. Is there any advice that you would give to overcome or avoid that?
PPE kit should not be wear, whether PPE 2 or 3 should not be wear directly. What we follow in our institute, we first wear the scrubs. Over the scrubs, we wear the PPE. Because this is plastic-like material. And
do you change the PPE kit after every patient?
No,
or
sir.
do you sanitize it with some chemical spray or something?
Yeah, we can we clean it with a disinfectant solution, and the other important thing over that we wear the disposable gown which remove after the, if we are using the aerosol generating procedure, it can be discarded after the procedure.
So what is your idea about this negative pressure room and all that some people, and what is the AIIMS protocol on that? Is there any protocol? Is there any significance?
Yes, sir. Yes, sir. Sir, in the previous question, I want to highlight one more thing. When anyone is using the PP, whether PP 2 or 3, their material is highly inflammable. So especially prosthodontics, if we are wearing the PP 2 or 3, that's why it's recommended to wear when we are working on the aerosol generating procedure. If we on the split lamp, there are very much chances they may catch fire. So in the clinic also now we had placed the flameless burner also, but they cannot be used for every procedure. Sir, as you asked about the negative pressure room, in our institute also they recommended the use of the negative air pressure room when we are working on a patient where the chances of the aerosol formations are like that crown filtration or the in endodontics and all, they use the negative. If they said we must use the negative pressure room, it's not more than that. Is the isolation room like that. Negative pressure means the amount of air which is going out from the room is more than the incoming air, and the air which is going out from the room should not be open, is discarded directly into the atmosphere. There should be proper ducting system through which that air must go through the duct, and the duct contain the HEPA filter, high quality HEPA filter for the disinfection of that air. Then it is released into the environment. So it has slightly less pressure as compared to the surrounding air, so that the air from the corridor or the outside the operatory may flow inside the clinic, but it should not, the air in that room must not merge with the other rooms.
Oh, I mean, do you recommend the use of air conditioner? What do you do in the college? I mean, do you use an air conditioner?
Air conditioner can be used in our office, in our institute. We have a separate, although our building is centrally AC, but in the clinical area, AC is separate than the administrative area. And in the room where we are doing the aerosol generating procedure, it has the HEPA filters also, and we prefer to work on the chair. When we do the aerosol generating procedure, we prefer to open the windows on the clinical areas, so to prevent the stagnation of the area in the clinics. Because in the clinics, we are not working on the COVID patient. We are working on the COVID suspected patient. So we can open the windows. Even with the AC, we open the windows.
And there is a question on, like we are doing border molding for a custom tray. Yes. And we have to repeatedly, take out the tray from the mouth and go back and get back. What is your advice on how to take any precautions when we are doing that? They're removing it constantly from the mouth, going back, adding and coming back.
Yes, sir. If we are working, when we are doing the border molding, what we do, we can wash it into the running water in between the procedure, because we are working on the same patient. Anyway, we will add the green stick and then go into the same patient. Here come the role of unit dose concept. We should take out the green stick only which is the amount which is required. Suppose one green stick we think is enough for one patient, take out only one green stick. And what we can do in the operatory, remove all the extra things, keep only the material related to that particular patient. And in between the patient, if we want to adjust the tray and all, we want to touch the micromotor, then definitely we have to first disinfect the hand, and we have to wash or disinfect the tray also with the disinfectant before trimming it with the micromotor. In the laboratory, in our clinic, we are using the same disinfectant which we use for the disinfect the surfaces to disinfect the tray and all. We spray disinfect in between the procedure.
Right. And of course, there is a question on, is it okay to reuse impression compound, in the same patient?
Yeah, in the same patient we
There's
can.
No, I don't think. Yeah, right.
Yeah, in the same patient we can use it, but not in the other patient.
And what is your take on this digital impressions in this COVID era? Do you think they are going to be more advantageous than our analog impressions?
Definitely, this is a very good option because here the transmission of infection is very less. We are directly taking the impression from the patient mouth. Maybe, but they are, as till now, the digital impression are not very effective for the edentulous patient, our complete denture patient. Those can be used, although many studies are there, they can be used in edentulous patient. But in my personal opinion, not very useful for the edentulous patient, but for FPD work or the implant work, they are definitely very useful.
And there is, of course, some questions on how do you disinfect a temporary, provisional fixed partial denture, and also how do you disinfect trial dentures. I think you have already mentioned this. If you want to say something on
the same procedure I had explained in the pictures. We disinfect the bite rings. The same steps have to be followed for the trial denture or the temporary denture, or even that provisional restoration we are making for the FPD patient. Those can be disinfected either by spray or immersion. In our clinic, most of the time for the trial denture and the temporaries, we just drop them into the disinfectant. For every patient, once one patient is completed, we change the disinfectant solution also, and we use a separate solution for each patient and disinfect them by immersion for 10 minutes. That's why now we calculate the number of patients according to the amount of time which is required for each patient. So we are able to do less number of patients now as compared to previous.
Well, many questions are there on this UV light. Can you just throw some light on this using UV lights, for disinfection?
Sir, we have not used it and not using in our institution.
There is not much of evidence.
Literature also, although many studies are available onto the net also, but most of them are from the manufacturer side only. If we search about the scientific literature, it is missing that.
Right. Of course, you have already mentioned there were some questions on how to disinfect articulators and stuff like that, but I think that was already covered in the. Do you want to add something more on that?
No,
does all disinfectant materials, does it cause any damage to the articulator?
What I said to my students in the hospital, not to carry the articulator into the clinical area, unless they are very essential to carry in this infection time. Anyway, we are carrying them to the clinical area, either clean, either immersion. Immersion may destroy or may damage the instrument. They can be disinfected by either by spray or we can wipe off. We usually wipe off with the 1% hypochlorite or 2% of 2%.
And also, what is your take on the methods and means to reduce this aerosol generation? Can you just briefly give? Many questions are there on this aerosol. So, can you just briefly give?
What I can say here, wherever possible, we can use the micromotors. But many times micromotors cannot be used. Micromotor where we can use, like patient come to us with the screw loosening. So to open the access opening, which we have closed with the composite, we can use the micromotor. Or slight rounding of the enamel, sharp enamel, and those can be smoothened with the micromotor. And if polishing is required, minor polishing is required, we can use the micromotor. But in many places, aerotor is required, and we cannot replace the aerotor with micromotor and anything. So what can be done in intentional procedure or the activities can be minimized in this time. So we are also doing only the emergency aerosol generating procedures. This can be done.
Does autoclaving the aerotor handpiece regularly, does it reduce its efficiency?
No. We have to follow the routine protocol. We have to first dry it, then oil it before the autoclaving, then wrap it as recommended, then disinfect. Then put it in the autoclave. If we directly put it in the autoclave, definitely it will be destroyed. And dummy burr must be there in the instrument.
And again, does only cleaning the burrs by disinfectant, is it enough? after every patient?
No, buds can be autoclaved.
Okay.
Very well. No problem in autoclaving the buds.
Right. And some people are just asking you to elaborate a little bit on these autoclavable impressions that you, if possible. Is there anything?
Yeah, autoclavable impression. So really, I explained little less.
Right.
In the silicon-based impression material are available as an autoclavable impression material. 3-4 companies are providing autoclavable impression material. I personally never used autoclavable impression material. But what I find many studies onto the net, they have done the scientific studies onto the autoclavable impression material. And what they noticed when we use the autoclave the impression, once we took the impression after the autoclaving, there is some dimensional change. But in the other different studies, when we compare with the spray method or the immersion method, what they find, the changes in the dimension, although in the first 24 hours is more, and with time the dimension changes come to little normal towards the what they were initially present. And the amount of changes even in the first 24 hours into the autoclavable impression material is comparable to the what we when we disinfect the impression with either with the spray or the immersion. So no, there was no significant difference in the dimensional changes.
And what is your your advice or take on these extraoral suction apparatus that people are recommending for while during these aerosol procedures?
Sir, I think they will be very effective because these suctions will suck all the aerosol which will generate into the atmosphere. But because I have not used, so I can't comment much. We are using only intraoral suction, high power suction for the complication.
Do you believe that not allowing the patient to spit into the spittoon will reduce? In fact, just suck out water. Just don't allow the patient to spit.
No.
Is it going to help in any way?
Sir, that is not possible not to allow the patient to spit. Because
Right.
many patients don't feel it comfortable, even though we said the patient the water coming with the handpiece is a distilled water. As we use in the chair, distilled water, the distilled water is coming in your mouth. Even then, some patients don't feel nice to swallow that water. Patient has to spit, and what we can do, we can use the high power suction. So amount of spitting required is less. Or what can be done as soon as we ask the patient to spit, ask the patient to rinse with the mouthwash. What we are doing in our clinic, we keep the disinfecting solution or the mouthwash into the disposable glass. In between the procedure, we ask the patient to rinse with disinfectant. That further reduce the bioburden.
So I think more or less we have covered. I think everybody is asking almost similar questions otherwise. I think we have completely covered everything. You have talked about N95. There's a lot of questions on N95 especially, and you have given a very, very clear briefing on N95s. So I think excellent, Dr. Veena. I think we will stop with the question answer sessions. You have covered most of the things in the question answer sessions. Commendable. Thank you.
Thank you, sir. And I want to say thank you to everyone who were present during the entire session of my presentation. And I also want to say thank you to the entire DCI team for their hard work and making this endeavor a success. Thank you to everyone.
Thank you, Dr. Veena. And once again, I would like to, on behalf of the Dental Council, I am extremely happy again to announce the top 5 dental colleges in the country in terms of attendance for the webinar conducted on 9th August 2020. The Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Best Dental Science College, Madurai, Yenapoya Dental College, Mangalore, Srinivas Institute of Dental Sciences, Mangalore, Bojia Dental College and Hospital, Baddi, Himachal Pradesh. Of course, we would like to introduce the next webinar topic that is going to happen next Sunday, August 23rd at 4 p.m. It's on medical history influencing implant outcomes and digital technology in implantology. The presenter will be Dr. Gunasilan Rajan, maxillofacial surgeon and implantologist at Rajan Dental Institute, Chennai. It will be moderated by Dr. Indubhushan Kar, Professor, Department of Oral and Maxillofacial Surgery, SCB Dental College, Cuttack. So that is going to happen next week. We hope everybody is going to attend that webinar too. And I'm extremely thankful, and I would like to extend my sincere gratitude to the President of Dental Council of India, the Secretary, and all the Dental Council members for giving me an opportunity to moderate this session in these wonderful webinars that is being conducted by the Dental Council of India. I also thank them for this extremely commendable initiative, which is providing much needed updates and information on current trends in various aspects of our profession. I would also like to thank the speaker, Dr. Veena Jain, for her extremely informative and very useful lecture. And I have to also make an announcement that we have the highest number of attendees in all these. So far, we have about more than 16,000 attendees, and we thank on behalf of Dental Council everyone who has taken off their time to attend these webinars. And one more thing is that you don't need to fill up a feedback form from now. The feedback form along with the certificates will be sent to you by email, and you could just fill them up and send it at that point of time. So till we meet again, au revoir, all of you stay safe and take care. Goodbye.